Welcome to AETCM, the Emergency Medicine channel. Maybe for the next 15 to 20 minutes, we'll be discussing a small topic that is regarding antidotes. So, I'll be just briefing you what are the common antidotes that we come across in our day-to-day practice, and what are the basic antidotes that you should have in your emergency room when you are managing some toxicology cases. So, just I'll give you an overview of regarding antidotes. So, coming to the first thing, what is an antidote? An antidote is basically a substance that counteracts the effect of a poison. That's a pretty simple and straightforward definition. An antidote is a substance that counteracts the effect of a poison, and you have to understand that antidote is only available for less than 5% of the common encountered poisons. So there is for every poison you don't have an antidote, only for around 5% of the poison you have got an antidote that is available, and there is no universal antidote. That is what you have to remember. And there has been previous lot of discussion that there is something called as a universal antidote. At present, there is nothing called as an universal antidote. So, what is the mechanism of action of an antidote? So, the antidotes basically, when you discuss regarding various antidotes, they basically function in 6 ways. One thing, they form some inert complex formation like chelating agents for heavy metals like succimer, dimercaprol, or deep insulin for lead toxicity, Prussian blue for thallium, digobal TDTA for cyanide. So these are basically, they form inert complex formation, and as a result it affects its antidote effect. Then there is something called as accelerated detoxification, where the most common example will be N-acetyl cysteine and thiosulfate in case of a cyanide toxicity. And one of the next third part will be reduced toxic conversion. You are trying to prevent the toxin conversion of the other. So the commonest example of that will be methanol toxicity, where you can use ethanol as an antidote. And then the next pattern will be the receptor site competition. The commonest example will be naloxone for your opioid toxicity. And we can block the receptor site by giving a certain antidote. Commonly for organophosphorus poisoning, we use atropine. And toxic effect by bypassing the metabolism, that is oxygen for cyanide. So basically, whenever you look at any of the antidote, this antidote will function in any of these 6 mechanisms. So these are the basic mechanism of the functioning of an antidote. Now let's see quickly go on, because this is one of the favorite questions that whenever you are preparing for any of your entrance examination, whether it's your UG, NEET, PG, what are the common antidotes and their poison and their antidote that you should be aware. Paracetamol, you have N-acetyl cysteine. Cyanide toxicity, you have nitrites, sodium thiosulfate, dicobal EDT, and hydroxycobalamin. So remember that. And datura toxicity, you have physostigmine. OP and carbamates, you have atropine and pralidoxine. And there is no contraindication for the use of pralidoxine. Carbamate in carbamate toxicity, there is no contraindication for the use of pralidoxine. You can still go ahead and give, because suppose the clinical presentation will be the same, and only after a toxicological analysis we will be able to say whether it is an OP or a carbamate. And next thing is oxalic acid, calcium gluconate, iron, desferrioxamine, arsenic, British anti-levisite, lead, calcium disodium versinate, succimer, dimercaprol, or even D-penicillamine also can be used. Coming to the next common agents, that is copper, you have penicillamine, and diazepam, you have flumazenil, and methanol, you have ethanol or famotidine. Beta blockers, remember glucagon. Insulin toxicity, pretty simple, glucose. Opiates, you have naloxone, and isoniazid, you have pyridoxine. Thallium, you have Prussian blue. Warfarin, you have vitamin K, and heparin for protamine sulfate. Heparin toxicity, you can give protamine sulfate. So coming to the next most common one, convalescent poison, you can give diazepam. You are not very sure. It is not a, I am just telling you that the patient has got seizures, you can give diazepam. Poison causing anaphylaxis, remember adrenaline is the drug of choice for your anaphylaxis. Poison causing psychosis, maybe haloperidol, depending upon the QTC and other contraindication, you need to use it. Poison causing methemoglobinia, methylene blue, that is easily available. So methylene blue is the next agent that you can try. And poison causing metabolic acidosis, you can try sodium bicarbonate or hemodialysis. So that is the most important thing that you need to remember. So soda bicarbonate maybe always not be sufficient enough. Maybe you need to go for extracorporeal therapy. Poison causing bronchoconstriction, remember that salbutamol can be used. So this is a nutshell regarding various poison. Now I'll just go overview of common poisons that you need to remember, poison antidote that you need to remember, and how you are administering that. So the coming to the first one, that is N-acetylcysteine, you have got a lot of protocols available. So what we commonly protocol is called as a 20-hour protocol, and you also have a simplified protocol 20-hour, and there is another called as SNAP regimen which also can be followed up. So the common used one is the initial loading dose of 150 mg per kg IV over the first 15 to 60 minutes, followed by 50 mg per kilogram over the next 4 hours and 100 mg per kilogram over the next 16 hours. So that is the most commonly used regimen for your NAC. Also there is an oral regimen that you need to remember, loading dose of 140 milligram per kilogram per orally, and you have to maintenance dose 4 hours after the loading dose. You have to give at least 17 doses. So if the patient is vomiting, you have to repeat the dose after 1 hour. So that is most important thing that you need to remember. So N-acetylcysteine is the most important antidote. So when to give N-acetylcysteine? Whenever you have a PCM paracetamol overdose and you are plotting it in the Rumac methanomogram and it is above the treatment level, you can start N-acetylcysteine. But in certain circumstances, you don't have availability of a serum paracetamol level, and you are pretty sure that the patient has taken a toxic dose. Without any delay, you can start with N-acetylcysteine. So that is regarding your N-acetylcysteine. So the next most important agent, that is anti-snake venom. So anti-snake venom, as we will do a separate video on anti-snake venom because that itself will take a time. So just remember that whatever anti-snake venom available in our India, it's a polyvalent anti-snake venom. That is what is available in India. So it basically covers the Indian cobra, the common krait, Russell's viper and the saw scale viper, and it will not cover the hump-nosed pit viper and king cobra. So it will not cover. So it will only cover the big 4 snakes. That's I have already mentioned, and it is a polyvalent anti-snake venom that is available. So you have decided to give anti-snake venom when you will decide you have either systemic toxicity, or else you have got local signs, or you have got abnormal bleeding parameters or neurological weakness. You decided that this patient require an anti-snake venom. You need to start at a IV push method is also there. There is an infusion protocol is also available. IV push method is what we commonly practice, around 1 to 2 ml per minute. So you have decided to give 100 ml, that is 10 vials. So 100 ml you need to give it over a period of 100 minutes. So that is the IV push method. And infusion protocol, the same thing, you are diluting into an amoxicillin and you are giving in the same time frame of around 100 minutes. So the basic you need to remember that whatever you are planning to give, if you are planning to give 10 vials, you need to finish off with maximum 100 minutes. So not more than that. And there is no test dose for your anti-snake venom. So that also you need to keep in your mind. So that is just a quick overview regarding anti-snake venom. And coming to the next most commonly used antidote in our ED is the Atropine. Atropine, you remember, indication is OP, carbamate and nerve agent poisoning. Dose is 1 to 2 milligram bolus followed by 1 to 2 mg every 5 to 15 minutes until the chest is dry. So what you need to do is that the patient has come with the suspected OP poisoning. You started giving 1 to 2 mg of Atropine and you see the chest, how the bronchoria, everything is settled. Maybe the patient requires somewhere around 20 mg. You take approximately 10% of that. That is approximately 2 to 3 mg of that, and you continue as an infusion till the patient improves. So that is the dosing of Atropine that you need to remember in case of OP and carbamate. Definitely you don't see any major contraindication for the use of Atropine, and adverse effects, it can cause psychosis, anxiety, ataxia and behavioral changes and atrial arrhythmia. So it is well known, and special precaution should be taken with the patient who is having already with the history of myocardial infarction, arrhythmia, glaucoma, thick bronchial secretion and hyperthyroidism and pyloric stenosis. You have to be careful when we are using these drugs in these group of patients. So just that is the box warnings for your usage of Atropine. Now coming to the next drug, that is Praloxine. So it's basically an anticholinesterase overdose. Basically you will use in OP poisoning. That is what is indicated. Not in carbamate poisoning, but there is no contraindication for that. Remember that you need to start at a gauge of 30 milligram per kg loading dose followed by 80 to 100 mg. So what is available? It is 500 mg vial is available. So 500 mg into 4 you can give stat. Then 500 mg per hour you can start as an infusion for approximately for a 60 kg individual. That is an approximate calculation that I have given you. There is no absolute contraindication for that. But pain at site is very common, and there can be hypertension, tachycardia, drowsiness, paralysis, fasciculation, apnea. All those things can be seen in this group of patients, and you have to specific, very careful when you are using it for myasthenia gravis patient and with renal impairment. And as I told, carbamate poisoning, it is not required, it is not contraindicated as such. So coming to the next one, Naloxone, that is again used for opioid and clonidine toxicity. Dosing is 0.1 to 0.4 milligram IV or 0.04 to 0.8 milligram IM. whichever way it is available, and you have to be specific. The patient can have hypersensitivity to naloxone, so you should be avoiding that. And also keep in mind VTVF is common with this thing. So that is regarding your naloxone. And also you should have a special precaution. The patient might have symptoms secondary to opioid withdrawal also. So when you are giving this drug, opioid withdrawal is another risk factor that you are having. So that treatment also you should be keep in mind. And also coronary artery disease patient might develop hypotension, pulmonary edema and arrhythmia also. Now coming to the next thing, that is sodium bicarbonate. As I told, sodium bicarbonate is one of the agents that you can give in for a patient who is presenting with significant metabolic acidosis following a poisoning. You can give soda bicarbonate. Ingestion of toxic substance in 1 hour known to be absorbed by activated charcoal. For multi-dose activated charcoal, that's what you can give. Soda bicarbonate, the thing about soda bicarbonate is that the most commonly used is in tricyclic antidepressant toxicity. So tricyclic antidepressant toxicity, or whichever patient you have got metabolic acidosis, you can give. So whenever using soda bicarbonate, you need to keep one thing in your mind, whether we have got an 8.4% or a 7.8% solution with you. If it is 8.4%, it is 1 ml is 1 milligallon. So you can give 50 ml, means 50 milligallons will go inside. And the problem with this is that you have to be very careful. It is a hypertonic saline. Soda bicarbonate is a hypertonic saline. So the patient is already having some amount of pulmonary edema. It can increase the pulmonary edema, and it can cause hypokalemia, and it can worsen the intracellular acidosis also. So soda bicarbonate, you have to be you should be restrictive usage whenever you are suspecting a tricyclic antidepressant toxicity, or the patient has got very bad pH less than 7 following a poisoning. You want to buy some time regarding till the patient is going for a dialysis, you can do that. Otherwise, routinely soda bicarbonate, we are preferred agent will be in tricyclic antidepressant toxicity. So next is the activated charcoal. Activated charcoal is one of the most commonly, you can call it as maybe a universal antidote, but I don't feel, because you cannot give activated charcoal for all the patient. There are two types of activated charcoal delivery that you will do. One is a single dose delivery, and other one is multiple doses that you will give. So usually majority of the cases you need to deliver only one dose of activated charcoal. So usually it will be around 50 grams. So that is what you need to give, 1 gram per kg. You can remember around 50 grams you can give, and maybe multi-dose activated charcoal in very rare situations only you need to give. That situation you can give 25 grams every 4th hourly. So depending upon the type of poisoning, there is absolutely contraindications are non-toxic ingestion, unprotected airway, because if the airway is not protected, there is a high chance that the patient will aspirate. So we should not be using activated charcoal without airway protection. So make sure that you are protecting the airway and you are delivering the drugs, delivering the activated charcoal. And adverse effect, vomiting, constipation, fecal discoloration because the color is black. There can be aspiration of the activated charcoal, impaired absorption of orally administered antidotes. Some drugs that you want to administer as an oral antidote, it will not be absorbed. But special precautions, what you need to keep in mind, give via an RT tube or with a fruit juice, because it is not palatable at all. So, and also make sure that you are securing the airway before you are giving this drug. Now, the next commonly used one is glucose insulin infusion. So, glucose insulin infusion, one of the common agent where you can give is calcium channel blocker toxicity, beta blocker overdose and all. You can give glucose insulin. How to prepare, that is a question. You take 10% dextrose, you add around 2.8 to 3.2 millimoles of KCl to it. So you can add maybe depending upon whatever is available, you can add approximately that amount of KCl, and 1 unit per kilogram per hour or a short acting insulin, and you start at a rate of 100 to 20 ml per 200 ml per hour. There is no contraindication as such. If there is hyperkalemia, yes, we will not give, but usually this glucose insulin infusion can be given in patient. You can GIK, glucose insulin potassium infusion, or GIP, that is the common abbreviation that has been used. Adverse effect, you can have fluid overload, hyperglycemia, and if you are giving excess insulin, that can go to hypoglycemia also. So coming to the most people are very wanting to use this drug Flumazenil, but I will not say don't use it for every patient that coming with benzodiazepine overdose. So the most important thing that you need to remember is dose is 0.01 milligram per kg. So approximately 0.2 milligram over 15 seconds. That is what you need to give for an adult patient, and you can repeat after 1 minute to a maximum of 4 doses. Every 1 minute you can repeat up to 4 doses. In case of resedation, repeat the dose after 20 minutes to a maximum of 3 mg in 1 hour. So that is the maximum permitted doses, 3 mg in 1 hour. And contraindication, if you have got multiple drug overdose, don't use Flumazenil. You are not very sure the patient has consumed again something, because that is again, it can cause seizure prophylaxis, associated TC overdose, overdose of unknown agents, physical dependence. The patient is already on benzodiazepine for a long time. Do not use. Co-injections of seizure-inducing agent, known seizure disorder, and suspected rise in ICP. You do not use Flumazenil. It is not ideal. Where you can use it in patients who you know that you have given this drug, and because of this drug the patient is sedated. Suppose you are given in for a procedural sedation. In the ED, you have shifted the patient for a CT and you have given a midazolam or benzodiazepine, and the patient is not waking up and his airway is not getting protected. At that time, maybe you can use, maybe in a bronchoscopy suit, maybe in a suit, endoscopy suit, where these drugs are used as a procedural sedation agents. So otherwise, routinely Flumazenil is not indicated. Coming to the next one, methylene blue, as I told, methylene blue we commonly use in methemoglobinemia. So that is the time that when we have methemoglobinemia, maybe a dapsone toxicity, or you have a patient who is on leprosy treatment and he is taking on dapsone and he can come methemoglobinemia. You can give 1 to 2 milligrams per kg IV and repeat dose after 1 hour. So that is that you need to remember. Methylene blue is the drug, and contraindicated in pregnancy, G6PD deficiency and hypersensitivity. It is contraindicated. It can cause dizziness and also urinary discoloration and limb pain. So you have to be very careful. You have to tell the bystanders that you are using a drug that can cause this. So this is what in a nutshell I have covered. Certain antidotes, I have not completed everything. Just briefly describe few antidotes and their dosing, and we will continue with the series of antidotes. Thank you.